Test, 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 test.
So we just take it out.
Do you want me to do HDMI? That one?
No, you're fine. Thank you so much. So, thank you everyone who was just involved with that. I really appreciate it. So, my name is Matthew Bernier. I'm an 8th semester chiropractic student here at the university. I'll be graduating in T- a week and a half. So, congrats to the class of 2022. Real quick, I just want to give a huge thank you to Dr. Rosa and Dr. Honorato and the faculty at large for giving me this opportunity today. For me, it's just the cherry on top on my doctoral experience, and I'm really, really happy to be here, so thank you. So with all that said, let's get started. I had an awesome experience with a 26-year-old transgender male with a 4-year history of left upper extremity, chest, and posterior thorax pain. They came in with a 2-week history of an acute onset of diffuse, widespread chest pain of unknown origin. The patients went to the urgent care thinking they were having a heart attack like anybody with chest pain would. They basically ruled out anything sinister, EKG, CAT scan, you know, the work that you would get in any urgent care or ER, and they sent them on their way. Went to the PC. PC actually referred them to us, which is awesome, and then I started working with them. So basically, he described it as a widespread diffuse pain over the left side of the chest. It started as a 10 out of 10 in severity and decreased to a 2, 3 out of 10 after about a week. He was still experiencing that widespread chest pain. He said that he does feel some pain in the back of his left shoulder that almost radiates to the front as well. He describes the upper extremity pain as pins and needles and sharp shooting pain that goes down the entirety of the left upper extremity, from the posterolateral aspect of the left upper extremity down to the dorsum of the digits 2 through 4. So as you can see here, it's a very non-characteristic complex overlay of different pain distributions. As well, provocation included anything that involved abduction, flexion, and anything reaching overhead. One of the main movements that he said bothered him was actually putting on his shirt and taking it off. He said he had a lot of lancinating pain over the chest region, and that's something we'll go into why in a little bit. Anything else here? Just the stabbing pain with the initial episode, and now it's turned to a dull soreness. And for me, quality of pain changing does mean we've made some benefit to the overall presentation, and that's something we can talk about later on. If at any point anybody has any questions at all, don't hesitate to raise your hand. I'll answer you on the spot, and we can have a good conversation here. I don't want to lecture to you guys for 30 minutes either, if we can help it. So, functional deficits for this individual. Putting a shirt on and off, like I said, reaching overhead for objects, and fear avoidance, more specifically with exercise. This gentleman really enjoys going to the gym. It was something that he felt like he needed to stop due to his complaint. And I had a conversation with him on the first day, and I said, so and so, would you agree then that a part of our goal here for your treatment is to get you back in the gym? And he was all excited, and he said, yeah, it's something I definitely want to do. So establishing expectations with a patient, making them feel desires to not just their complaint, but also for the goals they have outside of the clinical experience is really, really important. So I'm not going to read through all the red flags, but the main thing I want to touch on this slideshow is the importance of understanding why we have red flags and knowing when it's most appropriate to refer. In this situation, the patient does have a history of weight loss, fatigue, malaise, loss of appetite, all these things that we would think are very, very sinister and need to refer right away. But with appropriate narrative and discussion and history taking with the patient, we came down to the understanding this is due to his generalized anxiety and clinical depression that has been diagnosed and discussed with his PC. So we don't necessarily need to push patients away when they have red flags. Just understanding the totality of the clinical appearance is really important on deciding where we're going to lead with this patient and when is most necessary to refer. Cardiovascular was not highest on my list here because of the fact he already saw urgent care less than a week prior to seeing me. So I felt more confident in it being more of a neuromusculoskeletal overlay in diagnosis. So Past health history, like I said, the patient has a history of GAD, clinical depression, panic attacks. The main thing I want to discuss here is that he has a bilateral mastectomy. So he actually received a transition surgery back in 2017 when he's biologically female, but he identifies as male. And that's a conversation I had with him the first day. There was some confusion in terms of the paperwork versus what was on the patient record. And I had basically sit down with him and say, so I see on your paperwork, you say that you're male, but on the schedule, I see that you're female. And I basically just said, how do you identify? He said, I identify as male. I go, great. How are we biologically? What are we biologically? And he said, I'm female. I go, great. So you have all the female parts? And he said, yep. And I went, great. So understanding here that we identify the patient as male, but also need to ask these female gynecological questions along the way. So just understanding that there are multiple aspects to this patient interaction. So the bilateral mastectomy was performed in 2017. And along with that, he started to experience left upper extremity symptoms within a week or two after that surgery. And he's had it since for the past 4 years. So the chief complaint, I would consider an acute presentation of a chronic, an acute episode of a chronic presentation. So he's had this for so long, they had an acute exacerbation of everything else that's going on. On top of that, I found in his patient records that he does have iron deficiency anemia. Back in 2018, I went through his records and he was here in the past, and his iron was extremely low, his serum iron. So we know more than likely normocytic, normochromic, maybe becomes microcytic chronically, but it's something that is being managed, and we'll talk about that in a little bit. And then family history, nothing too excessive besides ALS in the family for father and nothing else to report. So general inspection, he's very ectomorphic in his appearance, very skinny individual. Mild forward head carriage, nothing too crazy to think about or consider at this point. He did have a skin lesion over the right thoracic region around the level of T7, which the surgeon had told him was due to the surgery. So more than likely, he has an intercostal nerve irritation that caused a localized lesion on the posterior thorax. It was reviewed by Dr. Rosa in the back, and we realized that it was something that we didn't have to explore further because it was already confirmed by a surgeon a few years ago. The inspection of the scars revealed a bilateral scar along the lateral sternal borders, the inferior areolar regions to the lateral flanks bilaterally. So it was two big L-shaped scars that ran across on both sides of the pectoral margins. They were well healed, no signs of keloid and no signs of excessive bleeding or haphazard scarring that we'll be a little bit more concerned with. Other than that, everything was unremarkable, no other discolorations, abrasion scars, edema, no deformities as we learned. Any questions thus far? We all good with everything so far? Yeah. Yep, so that's actually something I failed to mention before. So he was on Androgel and Lupron. So he actually was on a topical hormonal replacement. So he was on what actually increases androgen in his blood through topical means. And he's not on it anymore, but he was prior to coming in for the appointment. So he stopped that shortly before he came through. And then, so soft tissue examination. So something to understand here is, at least for me clinically, I don't assess particularly for hypertonus in soft tissues. If I feel it, I'll report it. But what I'm mostly looking for is objectifying the patient's subjective experience. So what I mean by that is if I'm palpating a tissue, regardless if it's hypertonic or not, I'll ask the patient, is this a pain or the pain, and where does it go? So they'll say, more than likely, if it's a pain, I leave it be. I don't think it's clinically relevant. But if it's the pain, and it travels in the same distribution, I'll consider that clinically relevant and add that to my comprehensive diagnosis. So for this gentleman, the following tissues that are on the board here reproduce the symptoms to a T along the same distribution in the left upper extremity, as well as in the axilla and posterior thorax, as I previously explicated. And then I compared bilaterally, as you always should, in the right upper extremity. For me, had a decrease in hypertonus, so there was a difference in tissue resistance under my fingers, but subjectively for the patient, there was no symptoms to report, no peripheralization, no localized tenderness. There was definitely a gross objective difference from side to side. So it's always important to check both sides of the patient to compare bilaterally. Yeah.
What dominance is the patient, right or left?
He's right dominant. We could go into the concept that we're all right dominant to some capacity just because of the way our organs sit. But I would say for him, he was a little bit the classic like leaning to the right, so his right shoulder was a little lower. We all tend to kind of brace a little more on the right. But yeah, so he is right dominant. So I did ask him that too. Good question. And then orthopedic examination. So we have a shoulder complaint. We always want to rule out thoracic, cervical, and global range of motion throughout. That's just something that I tend to do whenever I have a shoulder complaint or anything there too. So cervical range of motion. He has a secondary complaint of headaches that we're actually going to be treating now with a 7th semester intern. But cervical range of motion did not reproduce any symptoms down the arm, as well as the following tests that you can see for the cervical region. It did not reproduce anything in the upper extremity at all. Thoracic range of motion just caused bilateral rotation sensitivity along the mid-costal vertebral regions of about T7, T8. For me, when a patient presents with potentially a rib sensitivity, I'm always checking rotation and I'm always checking breathing and expansion. So for him, he had sensitivities with breathing and he had sensitivities with range of motion, more particularly with rotation, which is one of the main biomechanical drivers of the ribs. So just something to keep in mind here for your own clinical pro. GHJ range of motion, as I said previously, reaching overhead was a big problem for him. So in my mind, I was expecting passive and active abduction to be painful, and lo and behold, it was, more particularly over the lateral aspect of that left scar. So it was local, it was, as he described, as excruciating, and it just traveled slightly laterally, but it was all localized at the level of the scar. And then Shuffleman's test, just to check general soft tissue of the thoracic spine. Away from the lesion, he elicited a dull pulling pain over the scar and the lateral thorax on the left side. Any questions on anything to do with the orthopedic or soft tissue assessment? Awesome. So neurological examination, the patient was 2+ bilateral symmetrical DTRs, actually probably some of the best DTRs I've seen. Sensation is the really interesting part about this gentleman. So I did my upper extremity on the left side and the right side. There was actually an increase in reactivity and sensitivity of sharp and dull and light touch in the left upper extremity in all distributions, C5 all the way to C8, T1. Understanding here that for him, he could feel the sensations, but he couldn't distinguish them when he actually would jump off the table. He was very apprehensive to actually having the needle and the dull side as well as the conch. He was very, very sensitive to all three. Keep that in mind as we explore what actually happens later on in the treatment experience here. As well, I went and checked the thoracic dermatomes, actually, just based on the presentation and there being a rib pectoral presentation outside the lower dorsum. And lo and behold, he had the same exact distribution, roughly from T1 down to T6, T7. He could not feel really anything besides being very, very sensitive and very apprehensive. As I transitioned from the mid-thoracics down to the lower, he actually could distinguish it a little bit better, but it was still hyperreactive. So understanding that pattern is what I want you guys to think of right now. So we have mid-thoracic down to moderately low hypersensitivity. And then as we transition from T7, T6 to the lower thoracics, we still have reactivity, but it was better than the upper. So just keep that in your mind here. Motor was 5 out of 5, bilateral symmetrical, no issues there. And then, And then pathological reflexes were unremarkable bilaterally. There was no signs of upper motor neuron lesions, as well as with the history. So our chiropractic examination, I personally don't use the clinical narrative as joint restriction. That's just my personal opinion. I tend to ride with joint sensitivity. I think it's a better narrative for patients and it decreases the risk of fear avoidance and catastrophization of patient symptoms. So I just go with joints being mechanically sensitive. So I tell them, I'm going to push on some of these joints. They may be a little bit sensitive for your complaint. Just let me know if you have any pain or discomfort and if it reproduces anything that you feel is relevant. So joint sensitivity noted the entirety of the left side, P to A and right rotation. P to A, T7 and T8, which is similar to the rotation aspect of the thoracic spine we talked about earlier, as well as the entirety of the left costal vertebral joints, all the way from rib 1 down to rib 12. Springing on all of those recreated hypersensitivity and an increase in symptoms for the patient. Most interestingly, though, ribs 3 and 4 created an actual referral to the front of the chest and recreated the exact acute onset, which was the chief complaint when you first walked in. So understanding here that palpation is really crucial and really important to give you a better understanding of tissue sensitivities and whether or not they're relevant to the patient's chief complaint. Any questions at this point for anything? Good? Awesome.
You have a question?
Yeah, what's up?
When you palpate ribs 3 and 4,
Yep.
did you feel that there was more hypertonicity?
Yep.
Just through the, was like scar tissue and everything?
Yeah, so I think So the way I look at things clinically, it's a neuromusculoskeletal sequela. So I look at things as an all-encompassing diagnosis involving multiple tissues as well as the psychosocial factors of the patient. In that circumstance, I think that was more so joint-oriented with associated hypertonicity of the erectors and intercostals. So when I did a lighter palpation of the erectors, it didn't elicit on the thoracic as much as deep, more direct percussion or thrusting onto the joint, which elicited the actual referral. So I think the palpation differences really gave me a better idea of what potential tissue sensitivity could be involved. Does that make sense? Awesome. Good. And then, so the diagnosis, when Dr. DeMond was here, we kind of ran through a Globin-Faribault idea of all-encompassing highest level diagnosis. So here we use time, side, and then the multiple tissues that may be overlaying from the patient's complaint. So we went with a chronic left-sided post-mastectomy pain syndrome with associated myalgia, neuralgia, and segmental joint dysfunction in an anemic transgender male that's 26. That's just something more for intellectual banter, something to kind of help with your education and to give you a better understanding of how multiple pieces can be involved with the diagnosis and not just one particular issue. Understanding that pain is very multifactorial and complex, and that we have multiple contexts involved with the patient presentation. So take that as you move forward. I think it's an excellent way to go about it personally. So let's have a conversation about post-mastectomy pain. I went through, or before I even do that, based on the patient's history and them stating that it occurred just after the mastectomy, and just understanding that the symptoms occurred around the scar in the pectoral region, I made the decision with Dr. Rosa in the back there, hey doc, you proud of me, that we had a incident due to the mastectomy itself. So we didn't even look into anything to do with post-mastectomy pain until a little bit later on. So that's kind of like what we were hypothesizing and trying to run with. So I went and looked at a few studies, and lo and behold, everything kind of matched up, almost textbook for this guy's complaint, minus the peripheral symptoms. So post-mastectomy pain is a chronic neuropathic pain syndrome that, based on the literature available, is greater than 3 months in duration. Typically, it involves pain and sensory loss or hyperreactivity in the anterior, posterior thorax, axilla, and or upper extremity, and it can occur in multiple different pain patterns depending on different tissues and psychosocial overlay and other contexts I'll discuss soon. So basically, it involves damage to major peripheral nerves due to the actual surgery. So when they go in, they remove the glandular tissue and parts of the breast tissue that interferes with the overall peripheral distribution within the pec, as well as the glandular tissue in the breast. Nerves that are involved here that we'll talk about in just a minute is the intercostal brachial nerve, intercostal nerves generally from T2 to T6, T7, kind of see the relevance there a little bit, as well as the lateral and medial pectoral nerves, as we know are major motor drivers for the pec. As well, intercostal neuromas and phantom breast pain are also involved. Phantom breast pain is kind of similar to phantom limb syndrome, where we feel like we have the appendage there. We feel like we can still perceive the tissue that was once there. And we actually still experience symptoms that feel like it's that actual tissue. So patients with removal of breast tissue do have that presentation at some circumstances. Intercostal neuromas are actual, they're not tumors per se, but they're overlay of scar tissue, as well as neuronal tissue that occurs post-trauma, particularly in peripheral nerves. Two types of neuromas are terminal neuroma and then neuroma in continuity. They're just two concepts of peripheral nerve lesions where the terminal cannot regrow because it's completely lesioned the axon. And the continuity one is where there is some damage, but there is room for neuronal regrowth. Based on the literature available, I gave a range here, 23.9 to 60% of all patients with a mastectomy do have some form of post-mastectomy pain. A majority of the literature that I found is based on breast cancer patients. As well, I did find a study or two that related to transgender patients with their transition into male from female. And then care medically, what's in the literature for this is nerve blocks, adipose injections, and conservative management, most particularly with physical therapy. Any questions on the diagnosis of post-mastectomy? All good? Awesome. So let's have a little conversation here about the breast tissue and the various innervations of the breast tissue. So as we know, we have the areolar region as well as the teardrop of the breast that runs down to the mid intercostal region. So main nerves that are involved based on the literature that I found are the intercostal nerves that run from the posterior side of the costal vertebral joint to the sternal borders and lateral borders of the breast. They innervate somatosensory information and visceral feedback from the breast to the central nervous system. As well, we have the lateral and medial pectoral nerves, as we know, are the medial and lateral cord of the brachial plexus, and they innervate primarily motor for those tissues, for the pec. The main ones I want to talk about here, though, are these guys right here, and then one more additional. The medial brachiocutaneous nerve, it arises from the medial cord of brachial plexus, that's primarily sensory for the breast tissue and the pec, as well as the inferior brachiocutaneous nerve, which arises on the posterior side from the radial nerve. It's like additional ones that Priscilla probably never went into a lot. And they innervate the axilla and the posterior aspect of the upper extremity. The intercostal brachial nerve, which is like the main one the literature showed, involves sensory distribution to the medial upper extremity and the axilla. And that's the main one that they have reported to be lesions during this type of diagnosis, during the actual surgical procedure. As well, this gentleman didn't have any sensory loss up top, which would make sense due to supraclavicular nerves being above the plexus of nerves that I just previously talked about. They're more higher up and more central to the brachial plexus. So just some things to keep in mind here, and those are the main drivers of this post-mastectomy pain. So as I said before, the clinical presentation involves multiple factors and potentially multiple tissue sensitivities. For this gentleman, palpating the subscap actually recreated a classic myotogenous pattern down the backside of the arm to the dorsum of the hand into those digits. And as you can see here, based on the Travell pattern, he recreates exactly that, a little bit of shoulder, a little bit of medial, and then a little bit of palmar. He had some palmar symptoms with the brachial plexus tension test, but more particularly for muscle and myalgic influence, this guy had peripheralization in exact symptoms with subscap as well as pec. Pec produced more anterior and a little bit more ventral, where the subscap is a little more posterior. So just some interesting stuff to keep in mind here. Dermatomal patterns, just decided to throw this up for a little bit of a remembering here. So as we know, the dermatomes kind of run a little bit more symmetrical across the spine. As we did sharpen, dull, and light touch, we did see there was a complete loss between T1 down to T6, T7, which I said before innervates those main muscles within the axilla. So between T1 and T6 is the main influence of post-mastectomy pain, which would make sense why between T1 and T6, T7, he had an increase in hyperreactivity of sharpen, dull, and light touch. So it kind of comes all together here, all encompassing. And then sclerotogenous referral patterns. So this comes back to what we're talking about with the joint stuff, my friend over there. So when I sprung on those joints, a little bit more of a deeper push on those joints, it did recreate the exact dermatomal pattern, which is the chief complaint. So as we see based on these sclerotogenous patterns, he had pain directly over T4, T3, went right lateral, or left lateral, I should say, it came all the way to the front and created that diffuse, widespread pain in the left side of the chest and made him think he had a heart attack. So just understanding that there's multiple tissue sensitivities that may be involved, and again, it's multifactorial there. So, passive treatment. After sitting down with him and having a great conversation about what post-mastectomy syndrome is, basically I told him that your body is like a map. I use narrative. I think narratives are really important for patients to better understand what's going on and to not make them fearful of their complaint. So I essentially told him your body is like a map. Your body originally recognized it as the US, and now it's trying to recognize it as Europe. It's just a different landscape that your body's trying to figure out because there was a great deal of trauma in that area. So it's just some things to keep in mind here and giving a better understanding as to why he's experiencing symptoms and why he has all these differences in pain patterns down the chest and the arm. So manipulation was applied to all segments except for the ribs. The ribs were very sensitive, so I decided not to apply a grade 5. I did an iliocostal mobilization, so basically the patient's prone. You hook onto the ASIS and you gently push into the ribs on the lateral side. As well as direct hypophenar P to A on those upper ribs. You can't really get that with an iliocostal mobilization. 2x10 pin and stretch was applied to the left pectoral scar, pectoralis major, as well as the subscap. All three reproduce peripheral symptoms during, but alleviated after treatment. The main one I want to talk about here real quick is this guy. I specifically targeted pin and stretch for the scar into abduction and lateral flexion. Reason being is because the main thing that bothered him was putting his shirt on and off and reaching overhead, which is the main motion here. So I decided to desensitize the structure based on the movement that is most sensitive for him in his daily life. So that's just kind of how I went with that. And then muscle stripping was applied to the rhomboids. And like I said, they all reproduce peripheral symptoms into the left upper extremity. And then active care involved progressive loading strategies, reassurance, and lifestyle modification, which I'll briefly talk about in the next slide. So, very simple prescription. It involves 2 to 3 sets of 5 to 10 repetitions daily. So basically, I prescribed him cat and camel exercise. The ones on the left side here are actually more spine focused, and the ones over here are more shoulder focused. The main difference is where I shifted my body weight. So the first initial weeks of care, first week or two, we're working on this side, really working on spinal motion. And then all we simply did after a week or so is we transitioned him a little bit more forward and worked through the shoulders. Had a huge burn in the shoulders, and he felt less in his back when we kind of shifted his weight forward. So just understanding there's a little bit of nuance with active care, and you can use the same movement, but you can just kind of change where the center of gravity is and kind of change what he's actually using during the movements. To promote overhead work, I did a closed chain forward bend exercise on the wall. He's had to put his hands on the wall and find various degrees of motion that were comfortable for him and kind of hinge into those positions for the prescriptions I had listed here. Later on, we started to do some more direct eccentric stretching, whatever you want to call it, work with the pec and the scar. We had him essentially lean through the wall and take some big breaths into end range to really expand those ribs and help the ribs do their job. Granted, this is the initial phases of care. We progressed to these a little bit later, and this one was here at the beginning. And then this guy, we came into the last week of care. And now he has all those tools on his own. Any questions on the active care components of what I did for this guy? So there were some clinical challenges. The first day, I did pin stretch the pec, and he had a 5-minute loss of sight in his left eye, a little bit of visual acuity. So if you really think about it, TOS can present with ischemic loss in the eye, just due to compression of the vascular structures as well as the neurological structures there. I wasn't freaking out about it. I told him that's more likely normal because we compressed the brachial plexus, but also the axillary artery and all the various blood centers that go through the shoulder. So we basically had to sit down and go, listen, give it 5 minutes, and have Dr. Rosa come in and run a quick eye exam. We screened him, he was perfectly fine, vision came back, sent him on his way. After that first appointment, we started working on other sensitivity structures and then slowly progressed him back to working the pec. So after about a week or two, we started to reintroduce the pec work, and he never had visual loss again. So just understanding that sometimes things can be a little bit crazy on the table, but at the same time, we just have to work through them, give reassurance, and understand that we sometimes can have weird symptoms with presentations. Reassurance with recurrent symptoms during care. As we went through, I basically told him the treatment experience is like a highway. Sometimes we have to take different exits to get back on the same track and keep moving forward. So along the way, he did have some increases in symptoms. He had some exacerbated chest symptoms where he had to basically figure out how to do it on his own, which is awesome. So he basically found some movements that he could do based on what I prescribed to him to help to desensitize the rib and the muscles in front of the chest. And he said, he came in one day really proud. He goes, Matt, I had really awful chest pain, and I did what you said, plus a couple extra things that I came up with on my own, and I decreased my symptoms all by myself. He was all happy. I used no book. He was really, really happy. So just understanding that patient empowerment is also really important. Fear avoidance of activity in active care. So at the very beginning, like I said, he was very fear avoidant to go into the gym. After having a conversation, just de-escalating his symptoms and validating that he can go to the gym, he finally started going 2 to 3 days per week. A little bit later on to the care plan as he started to feel better, and now he's in there about 2 to 3 days, sometimes 4. I have also given him physical activity guidelines based on ACSM of 2 to 3 days per week, trying to get him to 150 minutes per week. It's been a work in progress here, but basically 15 to 30 minutes on a bike, aerodyne, or stepper, and that's something we've been trying to work on together. It's a little difficult right now, just because he's very busy driving Uber, and he's always busy, he's always working. And then managing active care with his daily schedule, because he is an Uber driver, he's working like 9-10 hours a day. He's always in one position for a very long time. So we encouraged him in a safe environment with his car turned off and all this other stuff, making sure we cover our bases. We had him get out of the car and do the same exact exercises on the side of his car. Granted, he may look silly, but he didn't care. He goes, I want to feel better. So he started doing his work outside of his car when he had breaks in between, and he found a great way to manage his schedule on his own. So a lot of check-ins back and forth, making sure he was managing it right and coming up with better ideas on how to schedule his active care. Results of care. He ended up having a full resolution in about 3 weeks. I wasn't expecting that. I think Dr. Rose and I can agree that we're confident we can help him, but I didn't think it was going to happen that quick. I didn't think it was going to be a full resolution either. Obviously, there are some psychosocial factors and some yellow flags that were involved, so that could be a part of it. But for him, objectively, there was no more palpable findings with peripheralization, and even for me, the hypertonus was less actually under my fingers. Full sensory restoration. So when the pec, upper extremity, and in the thoracic, he didn't have apprehension at all. And he actually had full description of sharp and dull and light touch throughout all those regions. He knew them to a T. He actually messed up one on the right, which was kind of funny. So he messed up one on the right and had it 100% on the left. Doc was in the room. That was a really cool experience that we had with him. He was happy. He was ecstatic, and he could feel sharp and dull and wasn't jumping off the table. It was great. Unremarkable orthopedic tests, cervical spine, some orthopedic or some occipital referral, localized pain, as we talked about, but nothing brachial plexus, no shoulder motions, nothing bothered him or reproduced peripheral symptoms. I failed to mention that during this entire process, when he started to centralize his pain, the peripheral symptoms became less. He had increased thoracic pain. So in the McKenzie idea, when peripheralization decreases, central pain increases, at least transiently, just a part of how the patients tend to present with certain neurological conditions. So for him, I really made sure he knew that it was a good thing that he had increased pain in his back and that we're going to keep working through it together. So a couple of thoracic manipulations on top of some more range of motion work and reassurance cleared the rest of it up. Increased self-efficacy and empowerment. Again, he found a daily schedule that worked best for him with his active care, and he was very proud of himself for coming up with it on his own. He started supplementing with iron and St. John's wort. St. John's wort for his anxiety, as well as an iron supplement that I made sure he was a complex that was supplemented with vitamin C. As we know, it's a main driver of absorption for iron. We need to make sure he had that in there so we wasn't getting any ulcers or anything crazy in his GI tract. All of that was referred by his PC and prescribed, so we're all set there. Hydration status, half of body weight in water I want him to drink per day. I just thought because of the anemia, anxiety, and lack of hydration for him, period, he said he didn't drink a lot of water. But he'd always come in with a water bottle saying, look, I'm drinking, and he'd have half of it full, a little bit less. Because he's feeling so good, he didn't really say this to me, but he's just like, Matt, I'm applying to college. So he was kind of indecisive in the very beginning if he wanted to apply to school. But just something to add that he kind of found was best for him is to start applying to colleges, and he wants to become a clinical psychologist, just kind of based on his life and where he's been and where he's going. So that's an awesome thing for him. And of course, which is my favorite, he's back in the gym. So he's back in the gym 3-4 days per week doing this thing. And yeah, at this point, he's doing awesome. Understanding that there may be some increases in symptoms, which is perfectly normal, and that he has tools to manage it on his own. And then when he feels like he can't, he can always come back and get a reassessment. We can kind of work with him a little bit more. And then there are my references. Any questions at all, let me know, and thank you very much. Eddie, what do we got?
Did you have any conversations? I noticed earlier the diet seemed pretty poor as far as like fried foods and stuff like that. And between that and exercising going forward, was that conversation had with the patient?
So I like nutrition. I respect nutrition. I've taken a lot of nutrition classes, but I am not a nutritionist or a dietitian. So for me, I manage it as much as general aspects of what to make sure he's doing. So I really paid more attention to the hydration and then him understanding that he could eat better, and he knows what better is. More vegetables, a little bit more lean meats during the week, some couple pieces of fruit in the day. Like he knew generally, but I didn't prescribe it to him.
Okay.
For me, I'd rather refer that out to somebody who dedicates their life to doing it. And I know it's within our scope, but it becomes difficult for me to kind of work on all those aspects. So I did as much as I could and what I felt I was comfortable with.
Gotcha.
So, anything else? Good. Yeah. Yeah.
So back to the hormone.
Why did he?
When you said
Yeah. It was about a couple months prior to the initial appointment.
Okay. And then he went on the iron after.
Yep. Yeah, so he was on iron supplements a couple years ago. He came off them for whatever reason. And then I said to him, I go, I really think you should go discuss with your PC about getting on an iron supplement. I didn't do any lab work. We didn't have that access in the clinic, but his serum iron his ferritin was very low on his blood work. So I made sure that he knew that he really should go get an iron supplement. He feels really tired all the time. He has a secondary complaint of chronic low-grade headaches. So I'm just like, I really think that's related to the anemia.
Also with the anxiety.
Yeah, right. And as we know in the literature, a lot of anemics have increased in psychosocial overlay. They have a lot of anxiety. Yeah, totally agree. Anything else, guys? Yeah.
When he first came into clinic prior, was this before
So he had surgery in 2017. He had no symptoms before the surgery. He just had breast tissue he wanted removed. He had the breast tissue removed. A week or two later, started experiencing left upper extremity numbness tingling, and then it progressed into this presentation.
Okay, so you didn't come into clinic prior with, oh, I
No.
need this, okay.
No, it kind of like over time it developed after the surgery. And he was like, no, I think it's from the surgery. And I'm like, I would agree, just based on it. No. Anything else, guys? Yeah. He's really happy with his progress, and so am I. Understanding that we play a part in the patient's experience and how they get better, but it's not just about us, it's about them and giving them the tools to succeed on their own. So yeah, really happy with him, really proud of it. So thanks a lot, guys. Appreciate it. Thank you. Good luck.
Welcome.